So now we go on to Dr. Sony's talk, and he is going to offer some tips on how to make multifocality a reality for many more patients, both by way of counseling and by choice of lens.
Good morning once again. With the present technology, we are able to offer multifocality for a wider range of patients. I'll tell you why. Because most of us, when you counsel a patient for multifocal, you look at the socioeconomic status and the profession of the patient. So most of the time, if it is a lady who is coming for surgery, who is a housewife, generally we do not counsel her aggressively for a multifocal lens or an EDOF lens. But it is very important for a person who cooks to have good intermediate vision. It is not only the patient who works on the laptop, but any patient who cooks, any person who paints, and any person who does such fine this thing in an intermediate distance. So earlier, because of the cost, again, the middle class usually used to be excluded from counseling for a multifocal patient, multifocal IOL. But now with the technology, we have much more lenses now. So we started with the array, rezoom, the restore, the trifocals, and the EDOFs, the VVT EDOF, and also two lenses from Indian companies, which have made it more affordable to the middle class. One is the aspherically modified EDOFs, like the iHands and the Swissfob from Apasami, which is an excellent lens, and a refractive-diffractive EDOF called Vivid from Orolab. So what are the considerations you have? One is the economics. Yeah, so economics, when it comes to economics, now we have the Indian counterparts which who are making very good lenses. We'll come to that. Photic phenomena was a very big problem. Like if you quote Dr. Mohan Rajan, multifocals used to be for house husbands and housewives. So we have moved a long way away from now. And astigmatism. So we never initially had multifocal torics. Now we have plenty of multifocal torics and EDOFs. And the functional working distance, near and intermediate. Now, there are a lot of people, I mean, in fact, all of us have moved from reading at the distance of 33 centimeters. I don't think anybody in the hall now reads at 33 centimeters. Our reading distance is receded to around 40 to 50, thanks to all the gadgets we have, the mobile, nobody reads books with very fine prints. So the redefinition of working near and intermediate is come through. So coming about the economics, the Indian multifocals, we have companies like Region from Apasami and Define from Orolab, which are good multifocals. And we have the Indian EDOFs, the Swissfob, which is basically aspherically corrected EDOF from Apasami. And we have the Vivid, which is a EDOF lens with rings from Orolab. So photic phenomena, that was again a problem. We had to, reduce our, catchment area to people who do not drive, who do not have already pre-existing glare, etc. But we have the VVT lens, which has really been a game changer. And we have the AT Lara from Zeiss, which again gives you good intermediate vision. And the Panoptics or the AT Lisa Tri, which are multifocals, trifocals, which have very much reduced photic phenomena. For example, when we had the initial multifocal, the loss of light used to be around 30 to 35%. Now it has come down to hardly 12% with the Panoptics, AT Lisa Tri, and the VVT. And the toric versions, I said, people with pre-existent astigmatism, you have to correct anything above 0.75 astigmatism if you want to get a good multifocality. So we have the VVT toric, the Panoptics toric, AT Lisa Tri toric, and the AT Lara toric. Unfortunately, the Indian companies still haven't come out with the toric versions. We hope they'll come out soon with those lenses. And functional working distance, again, the Vivid and the AT Lara will give you excellent intermediate vision and functional near vision. I'll tell you how I do it. And the VBT, again, it's a mark apart. Regarding the photic phenomena, it is almost like a monofocal. And functional working distance again. And the Swiss phobe, again, has got a good functional working distance. The intermediate is good. And with a little correction on the residual power, you can get even good intermediate vision. So this is the AT Lisa. You have intermediate at 1.66 and the ad is 3.33. And this is how the lens looks like. And we have the Panoptics, which works on the Enlighten technology. There's, like I told you, it's only 12% and has continuous range from 40 to 80 centimeters and the multifocal equivalence. So the AT Lisa, it works on the light bridge technology with 50% light for far, 15 for intermediate, and 35 for, distant intermediate and 35 for near intermediate. And this is how it looks like. I'll talk a little bit more about the Indian options. So here, Swiss phobe is a lens which is aspherically modified and aspherically corrected so that the central area gives you more depth of focus and some amount of residual minus, so that the patient is able to go for intermediate and near, and the peripheral portion is for the far. So the anterior refractive optic element gives excellent distance vision, and the negative aspheric in the periphery gives better depth perception and good night driving. And compared to one of the leaders, the Minivel IOL, they do very well in comparison. In my experience, I've done around 26 patients with bilateral implants. And this is the lens. So they have two injector systems now. The one which I am showing is the normal Medicel injector. They also have the Acrisov C cartridge-like injector system, which is disposable. You look at the lens, looking at the polishing of the lens, it appears fantastic, and that is because of the aspheric correction which has been done. The lens centers very well. And this is the post-operative pictures. You look at the surface polishing is excellent. And in my series, 66% of patients had an uncorrected distant vision of 6/6 and 34 had 6/9. And intermediate vision after 1 month, 66.7% had N6. And 26.7 had N8 and 6.66 had N10. And binocular uncorrected near vision. Here I'll tell you one thing. I always correct the dominant eye for emmetropia and the non-dominant eye by 0.5 to 0.75. So this helps in better near vision at around 40 to 45 centimeters. So I could get around 66.7% with N6 vision. Sorry about that. And around 26.7 N8 and 6.66 N10. So these patients are very happy, and there is hardly any visual disturbance because there are no rings and there are no shifting zones. And compared to Technics eye hands, actually I hardly could get any patient with N6 even with this micro monovision technique. And the Magnificent, actually I used to get around 29% N6. Comparatively, this is among the better lenses among the lot. Now coming on to the Auroview Vivid, this is again diffractive IOL. So this is the rhomboid of vision normally which the patient will have. And if you look at the monofocal lens, it gives you good far vision, almost as perfect as a virgin crystalline lens. There is hardly any visual disturbance like glare, flare, unless you develop a cataract in a normal eye. So this is almost similar to a crystalline lens in that way, but intermediate vision and near vision is almost nil. So when the bifocals came, they stretched the distance vision part slightly lower and the near vision little better, and a reasonable amount of intermediate, but the visual disturbances were very high. And when the trifocals came, again with the technology, the loss of light and the loss of contrast was reduced. So we used to get reasonably good intermediate vision, reasonably good near vision, and with lesser amount of photic phenomena. And with Vivid, what we are aiming at is to give much better intermediate vision, near vision which is functional, better distance vision, and minimal visual disturbance, almost comparable to a monofocal IOL. So this has got the central rings. There are the refractive area is around 3 millimeters with the central myopic zone, and you have the rings here which are responsible for the improvement in vision. And the refractive surface is the anterior one, and this is how it is spread out. And compared to the other lenses, the traditional EDOFs, you have better functional near vision and better contrast. And in my series of 21 patients with bilateral implants, this is how the lens looks like. I'll speed it up for want of time. This, you can see the 4 rings very clearly in this. Very well centered IOL. And these are the pictures. This is the day 1, day 2. This is 1 week, 1 month. And this is dilated, very well centered IOL. And here, in 5 patients, I get 6/6 uncorrected vision. These are the patients I've made them emmetropic in both eyes. And in this group, the right eye, the dominant eye gets 6/6 and the other one 6/12 because I've given a residual of 0.75 in the non-dominant eye. And the last 5, I've given minus 0.5 in both eyes, residue in both eyes. That's why the near vision, 6/9 vision. And so binocular uncorrected distance vision, the 11 patients had 6/9, 5% had 6, and the others 5 had 6/6 vision. Intermediate vision at the end of 1 month, 76.2 had N6 uncorrected, 14.3 had N8 in one eye and N6 in the other eye, and 2 had N8 in both eyes, but all of them had binocular vision of intermediate of N6. And binocular near vision, again, 66.67% had N6 and 33 had N8. And the visual disturbances, hardly any, only 1 patient in one eye which had a hard cataract, had little bit of, by the time his corneal edema, till then he had a little bit of visual disturbance which cannot be blamed on the IOL. And obviously the Vivity, which has got the, is called the X-EDOF, which has got the central portion and the belt around. And this gives, this stretches the wavefront forward and shifts the wavefront forward. And it is almost comparable to a monofocal as far as the photic phenomena, etc. is concerned. In fact, one of my patients said, I just went out for a drive just to experience the sheer pleasure of driving. So after putting in a multifocal, it's rare to get a patient giving you that comment in probably after 1 month. So this is how the lens is implanted. And like Dr. Anish said, it is always better to have a 0.5, 0.25 to 0.5 to 0.75 overlap for the better this thing. And this is the lens in the bag, perfectly centered. Always you should wash under. And this is the post-operative pictures, very well centered IOL after dilatation. And this is my data. Most of the patients had, with this micro monovision, minus 0.75 in one eye. I get almost N6, around 40 to 45 centimeters. So now presbyopia correction can be offered to more number of patients regardless of their financial status, level of activity, and astigmatism. Thank you very much.
Hello. Very nice. Sony, you can be there. We just ask some questions. Very nice presentation, Sony. I think you have covered the entire gamut of. Only thing is, do you consider the Swissphobe and this Hyans? I don't consider that as a multifocal lens at all. We call them unifocal plus lens. So it's got a slightly bigger advantage. The near vision is not all that good. Even if you make, as you rightly said, microvision, Swissphobe is also very good. I use good number. Hyans have used a very large number, but you don't call them multifocal lens. So we call that unifocal lens. You have the advantage of the price. The price advantage is there, and the Hyans or the Swissphobe lenses. I feel that is thing. Then regarding the what do you call the choosing the right multifocal for the right patient, that is, I think, is very important. What I do normally in my practice is that if a patient is relatively younger, very active in his profession, like night driving and playing golf or cricket or whatever it is, I give them the option of either Hyans, which is not a multifocal, of course, but I also put a lot of VVT lenses for these patients.
Yeah, VVT is a very good choice for
the photic phenomenon is very less, and this thing is pretty good. Only thing is the cost of the lens is
sky high,
very high. Patients who are really slightly above 60, 65 or not much doing driving, I go for Synergy or Panoptics. So you need to do a maths preoperatively, sit down with the patient. What is the requirement for them? Whether they use a lot of computer, or they use a lot of books or newspapers, or they work on the laptop, or they do a lot of outdoor activities. Depending on that, you have to choose your multifocal and follow all the protocols what Anish has mentioned in his talk as well.
Nowadays, for an affordable patient, if he's a retired professor, most of the time reading it is Italy or the Panoptics. For all others, literally, who are not still holding the book near, I think VVT is a much better option in my hands, or maybe...
absolutely. And similarly, if you have a very high myopia patient and relatively old patient, high myopia, these are all patients who are used to good near vision. I still put Technis multifocal plus 3.25, it's coming, no? 3.25 in one eye and plus 4 in the other eye, because they want good near vision as well, because they've been having good near vision throughout their entire life. So you need to customize the lens according to the patient's requirements. I think that is the key. I need to spend involves a lot of chair time, counseling of the patients, and tell them what is their expectations. Very important. Yeah. What do you do, Sandhya?
Sir, if I'm taking a trifocal lens, then what I do is I'll take the nearest hypermetropic power.
Yeah.
Because if you go for the nearest myopic, if you aim for the nearest myopia, then what happens is they'll have to hold it very close to the eye for reading. That won't be comfortable. So the nearest residual hypermetropic power I take for trifocals. And as I said, the working pattern of the patient and their lifestyle matters a lot. And if they are young patients, I go for rid-off lens. And then for elderly patients who are restricted to home, then I put Technis multifocal. But then the dysphotic phenomena are very high with these Technis multifocals because they are traditionally bifocal lenses. Then otherwise, I go for trifocal lenses.
Barrett Universal 2 is a very good formula if you use for such patients. And in that case, you just need to take the emmetropic values because they're bang on. And they can be used for a wide range of patients, even for post-refractive surgery patients or very high myopes. They could give very good values. But for hypermetropes, sometimes it may just go off mark. But that's a point to be considered.
Another thing
I just want to ask you one question. Do you have any criteria for this pupil size and IOL selection?
Yeah. See, pupil size, the newer generation trifocals and the EDOFs are not so much dependent on the pupillary size or the mesopic pupillary size. But in a trifocal or a multifocal, I would definitely consider the pupillary size. That is on the dynamic pupillary size. In a patient with a undilating pupil, I would be slightly hesitant to put up, because anyway you will be using iris expansion devices. But many a time you may get a very round pupil, but in certain cases, everything may not go wrong on a particular day. In that case, my choice will be an EDOF lens, so that it is not so much this thing. Or VVT. I have used VVT in after pupillary expansion for giving. But even a trifocal, I wouldn't be very happy